about, this is a sponsored talk from CCL. So we'll be talking briefly about pitavastatin, moderate intensity statin to improve the compliance and outcome. And there's a large-scale long-term surveillance study on 20,000 patients. And out of those 20,000, 19,000 patients were analyzed for drug safety, and 18,000 patients were analyzed for effectiveness. So what did we see? Well, in terms of improving the lipid profile, it does improve the LDL by 31%, improves the TG as well, and improves the HDL. So the good and the bad goes, so the good combination. It provides significant LDL reduction in patients with comorbidities. So if somebody's got a diabetes, somebody's got a renal disease, which so often happens in diabetic, or with a liver disease, it does improve the levels, LDL levels, by 27% with diabetes, somebody with a renal disease slightly more, and with a liver disease around 27%. In terms of dosages, I think the higher the dose, 4 milligram, more robust the action or LDL reduction compared to 1 milligram. But then again, you can use 1 to 4 milligram depending on what kind of patient you have and what niche levels are they carrying. How do we compare this newer statin with the older, much proven statins? The parameter, if you look at absorption, most of pitavastatin is absorbed compared to rosuvastatin, which means more robust action. Bioavailability is much more. Is it effective with the food? Not in this case, but we know that atorvastatin in the food does affect the absorption, so that needs to be considered. What about the renal excretion? In people who have got renal insufficiency, you've got to be careful with using rosuvastatin because it's cleared mostly through kidneys, so you've got to be careful about that. In terms of atorvastatin, that is not the case, but in pitavastatin, it's even not the case because most of it is excreted through the bile. And the range of dose, as we mentioned earlier, that it ranges from 1 to 4 as in comparable to 10 to 80 of atorvastatin or rosuvastatin, 5 to 80 milligram. How do we compare head-to-head with that? They are comparable to our old tested atorvastatin and rosuvastatin. So from the baseline reduction to a newer level after the use of pitavastatin, the LDL reduction is comparable to the older atorvastatin and rosuvastatin. In terms of LDL reduction, again, the dose dependent, pitavastatin 2 milligram, 57% compared to atorvastatin 10 milligram, but higher dose of pitavastatin is even efficacious, more than atorvastatin 20 milligram. So it is comparable to whatever we have got right now. It is tolerated well, and the adverse reactions, and I showed earlier in the slides that the side effects is one thing which people worry about, and there's a term called diabetic rheumatism. We often come across patients who complain of aches and pains, and they are on statins. Some of them do improve with the time, but the others don't. And I think we need to consider that whether it is a part of diabetic rheumatism or whether we are adding to the trouble with the drugs which we are giving for primary prevention, in this case statin. So that's something we need to be considered, but the adverse drug reactions are much lesser in pitavastatin compared to the other two drugs. CKS, creatine kinase, again reflective of the aches and pains, what do they have, and it's much lesser in pitavastatin compared to the other two available drugs. In terms of kidney renal protection, as I said, the most of the drug is secreted from the bile, so it actually sometimes, if anything, there's a degree of change in eGFR in rosuvastatin compared to pitavastatin, which actually improves, and same applies to atorvastatin. So these things need to be kept in mind if you're seeing patients with comorbid conditions. There's been a lot in the press about the diabetogenic effect of statins, and that has been documented by Naveen Sadar from Glasgow, and there's been other studies to suggest that there is some diabetogenic effect of statins, which is being seen in taurubacitin, rosuvastatin. We need to yet to confirm that, but as it stands, and what some of you know about Nadisa Dar, who works in Cardiovascular Disease Center at Glasgow, and they have done this study and they have commented on that. But one good thing about it is that this is at least improves the A1C as we see here with taurubacitin. So something which could be considered if you are treating a diabetic patient with dyslipidemia, which so often happen. So ladies and gentlemen, our patients, whether they're diabetic, non-diabetic, they've got ischemic heart disease, they've got a collection of risk factors present. And more often than not, in diabetic patients with dyslipidemia, this is something which we see every day. This is what we know, that this is going to happen one way or the other. And I think this is what we are trying to prevent, and this is what would make us humble, because this is something which is going to come. And we try to prevent all these complications when come. So in conclusion, I would say that 70–80% of people with diabetes die of cardiovascular disease. CVDs are multiplied with type 2 diabetes that need to be kept in mind. The ABC of diabetes management can reduce the complications significantly. Use of highest intensity statins may lead to non-compliance, as we look that this has been seen in the world. The studies shown. American Heart Association and shown in 2013 guideline, they recommend the use of moderate intensity statins in diabetic patients. In diabetes, LDL cholesterol need to be treated irrespective of the baseline, and pitavastatin is a moderate intensity statin and significantly improves the lipid profile, and the same statin has a better safety profile and complements anti-diabetic. So thank you very much, ladies and gentlemen.